This is a chest radiograph for frontal projection of skeletally immature patient showing there is a hyper transgradient left hemithorax with the mild hyper expanded lung. Right lung appear unremarkable. Uh, there is cardiac size appear unremarkable. Visualized bone and soft tissues appear unremarkable. So, on the basis of my finding, it's likely suggestive of left-sided foreign body aspiration. And uh, next, I advise the expiration inspiration view to confirm.
Thanks. Excellent. Pick up. But this is a child. How you ask him to hold or take expiratory?
Sir, lateral decubitus view.
Okay. So on which side?
The abnormal side, the abnormal side will be down,
Yes.
and normal side will be up.
So usually you put the patient on the abnormal side. So if it didn't change, that means what? Presence of one way.
If there is no change, it means there is somebody obstructing that lung. And if normally air move upward, so the normal lung air will move upward and its volume is reduced. But
Exactly.
the foreign body volume is same as.
So it's again important, Dr. Shahzad, that always we compare the lungs, the
Yes.
leucinogen sides. The history also is very important. If the family said he's fine, no fever, nothing, he's playing with nuts or some toys, then all of a sudden he start coughing. So always, you know, check the history very well. Very important to communicate with the ER, with the clinics, if the patient is also coming from the clinic, to ask about detailed history, and also again to check the asymmetry. You may call the patient back even and take the decubitus view, decubitus view to check.
Yes.
If you feel more retaining of air, that means there is a one-way valve, which is the case here. So the child here was taken to bronchoscopy and found to have, not like partially obliterating the left main bronchus.
Yes.
Thank you, Dr. Shahbaz. Newborn who developed
Yes.
distress.
Sir, this is the frontal projection of the skeletally immature patient of the newborn, as you have told me. In this way, I can see that cystic lucencies, these are occupying the right lung, right lung. However, the lung volume appears somehow increased because of these cystic lucencies. The left lung appears normal to me. I can appreciate the diaphragm on the right side.
You can appreciate or you cannot?
Yes, sir?
Can you appreciate the diaphragm or you cannot? Where is the diaphragm on the right side?
Sir, I cannot. I can appreciate along its medial side, but not on the lateral side. That is the costophrenic angles are not well appreciated, sir. Sir, as these are cystic lucencies of the variable sizes occupying the right lung, and and I can see that it is causing some mediastinal shift towards the left side also. And I can see a lucency which is traversing from the abdomen towards the right hemidiaphragm, towards the right lung base. In my provisional diagnosis, I will like to put it in the case of congenital diaphragmatic hernia causing mediastinal shift. So, as it is causing mediastinal shift, I will refer it urgent to pediatric gastroenterologist or pediatric surgery.
Okay, so if you want to rephrase your descriptions, that there is like multiple lucency occupying the left hemithorax with continuity to the intra-abdominal region through, especially through the medial aspect So that's, confirmed this is from the abdomen or from the abdominal cavity. In addition to that, that even the visualized part of the upper abdomen has a paucity of bowel gas, or they are, or it's devoid of bowel gas, which means the
Yes, sir.
whole is herniating through the right hemidiaphragm to the right hemithorax. Okay, and you didn't appreciate lung tissue on the right side, only maybe the upper part of the right lung is appreciated or compressed. So what do they call this type of hernia?
Sir, Morgagni on the anterior right side, which is more prominent on the anterior right side, Morgagni type of hernia, congenital diaphragmatic hernia, sir.
If it's on the left side, what they call it?
Boctalic hernia, sir.
What are the associations with diaphragmatic hernia?
Sir, these are multiple pathologies, likely vertebral anomalies, bacterial, and I can see in congenital, in some trisomies, sir, also.
But let's concentrate on the chest. What are the abnormalities that commonly associated with diaphragmatic hernia in the chest? Do you think this lung will be normal even after reducing the
pulmonary hypoplasia, sir?
Excellent. Yes, pulmonary hypoplasia, is very common associated with, because this is an embryonic, defects, and it didn't allow the right lung or the lung on the same side to develop normally. And
then, sir, I will go for CT to see pulmonary artery and findings to see pulmonary artery diameter and its wall. Yes, sir.
What else from CT? What else? Another things that associated with diaphragmatic hernia? What about?
So I can give you some DD of it, like CCAM and sequestration, which comes in the DD of CDH.
I ask you for like differential diagnosis of this cystic lung lesions, but we agree the multiple cystic lung lesions is communicating with the abdomen.
Yes, sir.
And that we conclude it is diaphragmatic hernia. Now we are talking about the association. We mentioned pulmonary hypoplasia. Then what about the heart? Is there any association?
Sir, TOF, tautology of Fallot.
Like congenital heart defects in general, ASD, VSD, associated with the diaphragmatic hernia. So you have to recommend also echocardiography. With the CT,
cardiac echography
is very important also to exclude any associated congenital heart disease with diaphragmatic hernia. Okay.
Right, sir.
So this is a preterm. This is a 25-weekers who was born with respiratory distress. If you appreciate here, this is the ATT, the nasogastric tube, umbilical arterial and venous catheter. Heart size and heart boundaries are very difficult to appreciate. There is white out of the lungs or opaque lung appearance with hazy granular pattern bilaterally. So this is the classic appearance of surfactant deficiency disease or hyaline membrane disease or RDS of the newborn. And it's very important to know the age of the patient to tailor your differential diagnosis. This is like a few hours post installation of surfactant through the ATT. You can see improvement in the right lung, while the left lung is not improving yet. So anyone can see why this happens. Like if there is a follow-up after like 12 hours, the neonatologist tell you that I started already giving inhalers. So what do you think? Why the right lung is improving while the left lung is not?
Sir, this is actually just from the projection of a skeletally immature patient. The ETT tube is noted in situ. It is noted just above the carina. There is complete inhomogeneous, almost complete pacification of the left lung field. and cardiac silhouette on the left side, as well as diaphragmatic silhouette on the left side, it is lost, and normal lung parenchyma, it is not appreciated. And sir, there is right lung as compared to the left. Right lung shows some normal lung parenchyma, as you have already told that it is responding to the therapy. Sir, the left lung showing opacity, maybe there is some mucus plugging due to some obstructive pathology. That's why it's not responding to the therapy.
If you concentrate, I know it's tough to see, but the left main bronchus is fine, and you can see is even air bronchus. Still, we need to know why this patient is responding only on one side, and the left is not responding here. Very clear. It's very easy because the ATT is low and the right main bronchus is straight, not like the left.
Sir, because it is moved downward.
Yeah, that's because the ATT is low, just as you mentioned, just above the carina, and the
we have to adjust the ATT.
And also they may need to put the patient on the left side down to allow the surfactant solutions or therapy to go to the dependent lung. So that's one of the tactics that a neonatologist may use to change the position of the baby to allow the surfactant to fairly distribute it through both lungs. It's very clear that the right lung is responding. Some areas still not responding yet, but majority of the right lung is fine now, and you can see the cardiac border, but the left lung is still not responding. And this is one of the things that you, as X-ray interpreter, you need to identify.
Yes, sir.
And this is one of the complication of therapy, which they call it barotrauma. As you can see here, there is bilateral pneumothorax. So this is due to like positive pressure ventilation. The patient developed pneumothorax. So this one of the complication of step lung or RDS of a newborn is the barotrauma, which could lead to pneumothorax, pneumomediastinum. Very, very rarely you may have a pneumopericardium.
Radiograph chest frontal projection of a skeletally immature individual. I can appreciate that there is extensive hair which is outlining both lobes of the thymus, giving appearance of angel wing sign. The cardiac margins are well maintained and discrete. Heart size is normal. The visualized part of the mid and lower zones of bilateral lungs show adequate aeration, and the patient is premature. So findings are in favor of extensive pneumomediastinum, which is a surgical emergency, and I will like to inform the relevant physician.
Yeah, so this patient has extensive pneumomediastinum, which is elevating the thymic lobes, as you mentioned, and surrounding the lateral borders of the heart. The lungs develop adequate volumes, but this is probably due to, but the patient is just after extubation, and this is probably due to positive pressure ventilation. So it needs to be recognized, although it's not that as emergency as the pneumothorax or tension pneumothorax. Thank you so much.
Right.
Another patient who is chronically ventilated because of, RDS. If you can see here, the patient has multiple tubes, even developed subpulmonic. This is subpulmonic pneumothorax. It's very important to identify subpulmonic. Despite the presence of chest tube, as you can see here, it's not helping the patient to get rid of this pneumothorax. And you see the diaphragm is depressed mainly on the right side, but also on the left side. So it's very important that even this loculated or subpulmonic pneumothorax needs to be drained by targeting it through the interventional radiology or under fluoroscopy guidance. whatever you put chest tube, it will not relieve the tension or the pneumothorax. So that's very important also to recognize and to tell the referring physician. And again, this is another patient with barotrauma, chronically ill, lungs are sick because of hyaline membrane disease. We end up putting big tail drainage catheter to relieve the subpulmonic left pneumothorax, as you can see, despite presence of 2 left side chest tubes, but the left pneumothorax was not resolved. So we end up putting a big tail drainage catheter here.
Yes, sir. So I am provided with a frontal X-ray, chest X-ray of a skeletally immature patient, and I can appreciate that there is a well-defined lucency within the mediastinum. It is surrounding the heart, and a part of it is going into the neck. And relatively, there is decreased aeration of the lungs noted. So this is outlining the heart, and I'm more suspecting of a pneumopericardium.
Fantastic.
With the pneumomediastinum. Yes, sir.
What they call the sign.
Continuous diaphragm sign.
Yes, continue. Although it's very rare to have pneumopericardium, but it's recognized. It could be due to barotrauma, positive pressure ventilation, due to trauma from, like penetrating trauma, very rarely due to gas forming agents causing pericarditis, but it could be seen in patients with positive pressure ventilation or post-positive pressure ventilation. So this is very important to recognize. If you see here, the thymus was not elevated and the air lucency is completely surrounding the heart. So that's very differentiating sign from the pneumomediastinum, and clearly delineated by what's called a continuous diaphragm sign. So thank you so much. Patient who is chronically ventilated because of RDS of a newborn, and it's almost like 4 weeks after ATT or intubation. And the patients start to develop, asymmetry in lucency of both lungs.
So this is X-ray chest frontal projection of a skeletally immature patient. The ATT is normally placed. I'm seeing multiple ECG leads, and also I'm able to appreciate that there appears to be umbilicus venous catheter and arterial catheter. They appears to be normally placed. And on the given images, I'm able to appreciate that there appears to be bubbly lucency seen in the left lung, which with surrounding hyperdense linear lucency, since it is bubbly. So there is history of ventilation for a prolonged period. And so I'm considering it to be a case of bronchopulmonary dysplasia. And also I'm able to appreciate that there appears to be haziness in the left lung, which might be due to some infection, because I'm able to appreciate air bronchograms in it. The CP angles on the left side appears to be blunted. So I will sum up my findings in the given diagnosis. This could be a case of bronchopulmonary dysplasia, and there's some infective process on the right lung.
Mm-hmm. But the patient is febrile. There's no leukocytosis. There is no sign of infection. And
so obviously, this is a case of RDS. So might be a possibility on the right side also, and a complication on the left side.
Okay. Let's take it one by one, Dr. Sinha. I told you that when we compare this lung appearance with the multiple X-rays done previously, it's almost stable with hazy granular appearance of the right lung. And the left lung was almost similar to this one, and all of a sudden it develops this bubbly lucency, which is going from the center all the way to the periphery with some sort of hyperinflation. You see, it's slightly hyperinflated, the left lung. If you compare the left lung to the right, it's slightly hyperinflated. So we mentioned that one of the barotrauma effect of the ATT is pneumomediastinum, pneumopericardium, pneumothorax, but also if barotrauma, involve the lungs, especially when you are giving positive pressure ventilation with a stiff lung. What will happen to the lung? What will happen to the air column within the...
Right, sir. And other possibility that this could be pulmonary interstitial emphysema.
Excellent. So this is very important because this maybe, goes to like more air leak along the pleura, causing tension pneumothorax, and needs to be followed up closely. So very important to recognize the changes in the lung lucency and to mention it to the neonatologist that this lung is really hyperinflated with probably interstitial lucences. There is signs of pulmonary interstitial emphysema, and the patient needs to be followed closely for air leak and for pneumothorax. There is an area of air trapping lucency. There is multiple interstitial thickening, some fibrotic bands, as you can see here, and also involving the left lung. Some hyperinflation of the lungs, but it's bilateral. So this is the features of the BBD. And even if you do a cross-sectional CT scan, it's you're gonna see how it involves both lungs at the same setting. You see here ground glass appearance, areas of air trapping, interstitial thickening, some bronchial wall thickening, and some also cystic formation. So it's like, a fibrotic lung changes in adult. If you see it in a pediatric age group, just dig for a history for neonatal ventilations, for RDS of newborn that happened to the baby in the neonatal period. So this is the characteristic features of BBD. So it is the end stage of RDS, and it mainly due to barotrauma and ototoxicity. It passed through 4 histopathologic stages. It ends up with like bubbly lung appearance and fibrotic changes in the lung, as you saw on the CT scan. This is the classic appearance. The lung volume are okay, but if you see here, there is interstitial thickening. There is like periventricular opacities, and also the interstitial is thickened. There is like a pleural fusion if you check here also. So the baby is fine only with mild respiratory distress. If you just follow up after 24 hours, you will see improvement. So that's the classic appearance of wet lung syndrome, or TTN, transient tachypnea of newborn. There's patchy opacities involving both lungs, areas of hyperinflation. There you don't see pleural effusion or signs of volume overload. Patient will be febrile. History of the mother will be having a conviction. So mainly the differentiation is based on the antenatal history of the mother. Another entity that affects post-term baby is the meconium aspiration, where the meconium usually stain below the vocal cords, and usually it affects big babies with diabetic mother. The appearance is hardly to be differentiated from neonatal pneumonia on chest radiographs. However, history is different. Like the post-term, there is history of passing meconium patients immediately, staining the meconium at birth on the baby face. So that's makes a differentiation from neonatal pneumonia in the history. Again, this is a patient with meconium aspiration. If the lung volumes again is the same. However, there is opacities involving mainly the right lung. Even the left lung is not completely normal. So this is very important to correlate with the patient neonatal history and the gestational age. So if you want to report the neonatal chest, always concentrate on the gestational age. The patient is preterm with low lung volume, think of RDS. If the patient is term baby with adequate lung volume on chest radiograph with multiple multiple opacities, think of neonatal pneumonia or TTN. If it's post-term, think of meconium aspiration syndrome. So this is a KUB or abdominal radiograph in a term baby showing good aeration of the bowel lobes. And if you take it by hours, usually the stomach is immediately filled with air after birth. A small intestine usually takes from 3 to 6 hours, while most of the baby would see air within the rectum after 12 hours. So that's very important to recognize the stage of pneumatization or gaseous distension of the bowel after birth, because it's very important to check for the presence of obstruction or congenital obstruction. So if you want to check the neonatal intestinal obstructions, then you have to know the level and to identify or to know the causes of level of obstruction. And most of the time we classify it as proximal bowel obstruction or distal bowel obstruction. Some people also call it high intestinal obstruction and low intestinal obstruction. So if it's high intestinal obstruction, most commonly duodenal atresia or duodenal stenosis due to annular pancreas, duodenal web, malrotation, but usually doesn't present immediately after birth, duodenal atresia or stenosis, very rarely to have gastric atresia, lower intestinal obstruction or distal intestinal obstruction. If it's involved the small bowel, think of ileal atresia or meconium ileus. If it's involved the large bowel, think of functional immaturity of the colon, or they call it meconium plug syndrome. Think of Hirschsprung disease, colonic atresia, anal atresia, or anorectal malformation. So this is how to classify it in general terms. And this is one of the newborn that was born and having abdominal distension, and a thoracoabdominal radiograph was done showing this appearance.
Sir, this is the X-ray abdomen or frontal projection of skeletally immature patient, in which I can see that a large lucent gross abdominal gut loop in the involving the left upper quadrant, traversing downward towards the right mid quadrant, and it is I can see that it is of bilobed type of appearance, in which the one lobe is, I can see that it is stomach, and I cannot appreciate any distal bowel gases and rectal air. That is distal small bowel and large bowel is not gasless. Also the ji sir, yes sir.
Yes, okay, go ahead. We're doing well.
Also the patient is in an ICU setting with some leads. In my provisional diagnosis, I would like to put it in the double bubble, that is duodenal atresia. I will go for ultrasound and barium meal follow through to find whether the cause is Lad bands or annular pancreas. Yes, sir.
Okay, excellent descriptions. One of the things also you need to mention in your report that to comment on the vertebral column because of association with factorial. So always comment on the vertebral column that I don't see any segmentation or formation anomalies.
Yes.
Spinal vertebrae are well formed. Plain film is very diagnostic for double bubble or duodenal atresia. We don't recommend upper GI or barium meal, as you mentioned, because of risk of aspiration. If it's completely obstructed like this with duodenal atresia, the patient may have aspiration. and you will not get any benefits. You're gonna just put the contrast for like a long time, it will not pass, and the patient may aspirate it. If there is no air distally with these double bubble signs, and most of the time it will be discovered antenatally. The antenatal ultrasound will discover that the stomach and the proximal part of the duodenum will be filled with amniotic fluids, giving a double anechoic sign. So because of ileoatresia. If there is air seen distally, then you can evaluate with ultrasound for presence of annular pancreas. Or you could do upper GI, especially if you see air distally, to check for any stenosis or duodenal web. So if you see air distally, you don't have a risk of like aspiration, so it's fine to go with the upper GI series. But if you don't see any air distally, we don't recommend doing an upper GI.